Hello, I'm Andrew Slattengren. I'm an associate professor at the University of Minnesota Department of Family Medicine and Community Health. Today, I'm going to discuss developing a family medicine rural training track in Minnesota. Minnesota ranks third in the nation overall in health system performance on dimensions that measure patients' health based on an analysis by the Commonwealth Fund. The University of Minnesota Medical School is one of the largest in the country, currently with two campuses based in the Twin Cities and Duluth. There's a long tradition of training students to become rural physicians, including our well-known RPAP program. RPAP is a 9-month community-based educational experience for University of Minnesota third-year medical students who live and train in rural communities across Minnesota and western Wisconsin. Shailat Prasad is Executive Director of the University of Minnesota Center for Global Health and Social Responsibility. He has extensive experience working in underserved areas around the world. He has been part of research teams in health services research and rural health and is actively involved in developing primary care in various parts of the world. Dr. Prasad is also the Vice Chair for Education at the Department of Family Medicine and Community Health here at the University of Minnesota. He knew from his research work on rural health that it would be important for us to grow the number of family medicine residents. Adding rural tracks to our existing residency programs is a way to add GME slots in the state. The locations of our residency programs reflects the highest density of healthcare providers in the state of Minnesota, with the exception of Olmsted County, home to Mayo Clinic. A recent healthcare workforce survey conducted by the Minnesota Department of Health found that 1 out of every 3 rural physicians was reported planning to leave their profession within the next 5 years. With this rural provider shortage present and worsening looming, our dean agreed that we needed to take action. Due to other competing priorities, he did not have the political capital nor the financial capital at his disposal to do this. What the dean did do was start a University of Minnesota Rural Health Guiding Coalition, which I was part of. An initial possible partner identified was Optum Care. After numerous meetings, Optum opted not to fund any family medicine slots. At the same time that those discussions with Optum were ongoing, our department was researching other funding options to support rural training tracks. This work was supported extensively by the Minnesota Department of Health Office of Rural Health and Primary Care. They assisted in grant identification, grant writing support, and provided some of the upfront funding. This included funding a graduate student from the School of Public Health who worked on identifying potential sites. Sites identified were all high-performing RPAP sites. Other considerations are that they're eligible to be certified as Medicare participating rural health clinics and have MERC funding. MERC is a grant in Minnesota for rural healthcare training that's been in place since 1996. There's tremendous interest across the state with hospitals and healthcare systems lining up to host rural training tracks. With that background, a group of leaders from our department met with North Memorial Vice President of Medical Operations about the possibility of adding a rural track to our residency program. They flat out said no. They specifically wanted to know that the funding was secured and they were not at financial risk. So we pivoted. Prasad and his team secured a grant from HRSA through the University of Minnesota Department of Family Medicine and Centricare to develop an additional rural training track in Wilmer, Minnesota, tied to our residency program in St. Cloud. This will start in 2025. Subsequently, Fairview Health Systems was awarded a grant through HRSA to develop an additional rural training track in Grand Rapids, Minnesota. Our Woodwinds residency program is now partnered with Grand Itasca Clinic, and that training will start as early as 2026. One of the MAFP legislative priorities over the last few years has been to expand the training of family physicians in rural and underserved areas. Through relationships developed over the years with state senators and representatives, along with lobbying efforts, we were able to advocate for the passage of the 2024 Rural Family Medicine Residency Grant Program. This grant funds a new residency slot for $400,000 annually and supports that slot for up to 3 years. With funding options present, we decided to meet again with the leadership at North Memorial. I met individually with the interim CEO as part of the LEADS program and opened up the idea again of our residency program having a rural track. After a subsequent meeting where our department leadership clearly outlined the current minimal financial risk, North agreed to proceed. Our department assisted in the submission of another HRSA grant for a rural track in the Lakewood Health System in Staples, Minnesota, to be partnered with the North Memorial Family Medicine Residency Program. With 2 funding sites secured for other residencies and now a third moving forward with North Memorial. Our next steps are to implement curriculum in all these rural track sites. Our department hired Dr. Bergeson, who has experience doing this elsewhere and will spearhead our efforts. There are ongoing efforts to educate our family medicine colleagues, as well as the people of Minnesota, that our medical school, and more specifically, our department, is taking initial steps to plug the rural provider gap.